Hello everyone, I'm Dr. Dilbag Kaur. I'm PGY2 Internal Medicine at Mercy Hospital, Fort Smith, affiliated with Arkansas College of Osteopathic Medicine. I feel honored to be presenting here today on topic titled AIDS, Opening a Pandora Box, focusing mainly on unusual presentation of Kaposi's sarcoma in AIDS patient. This case report was written with the help of my colleagues, Dr. Saloni Shirke, Dr. Kenichuko Edoga, under supervision of Dr. Dalila Isam. Kaposi's sarcoma is a vascular tumor primarily associated with human herpes virus 8. Its incidence increases upon initiating antiretroviral therapy. Kaposi's sarcoma typically presents with skin manifestations. Gastrointestinal involvement occurs in less than 10% of cases. This case is unusual in that Kaposi's sarcoma was unmasked by antiretroviral therapy, initially presenting as new onset dysphagia, which progressed from mucosal lesion to skin lesion as ART continued. This case is about a 38-year-old gentleman with no known past medical history who presented with chief complaints of shortness of breath, dyspnea on exertion, unintentional weight loss of close to 30 pounds, poor oral intake, and generalized weakness that worsened over the period of 1 month. On presentation to ED, patient had low-grade fever and was in mild respiratory distress, requiring 2 to 3 liters of oxygen, and was overall ill-appearing. Pertinent imaging, including chest X-ray, showed the findings of diffuse interstitial and alveolar opacity suspicious of pneumonitis versus atypical infection. A followed-up CT chest was done, which showed diffuse ground glass opacities and interlobular septal thickening with subpleural sparing, as shown in the images. Pertinent labs came positive for HIV with CD4 count of less than 20. Patient was started empirically on treatment with high-dose Bactrim, prednisone, and Biktarvy. Pulmonology was consulted and patient underwent bronchoscopy for bronchoalveolar lavage, which resulted positive for beta-D-glucan and Candida albicans. Meanwhile, PCR results came positive for Pneumocystis jirovecii. Following day, the patient had severe odynophagia and dysphagia with negative physical exam. GI was consulted and patient underwent EGD with some interesting findings as shown in the pictures, resulted as 5 mm reddish nodule in duodenal bulb with multiple raised nodules in stomach and antrum, containing central ulceration and reddish edges, highly suspicious for Kaposi's sarcoma. Also had diffuse white exudates throughout the esophagus, and biopsies were taken. Over the course of hospitalization, patient felt better and had a final diagnosis of HIV with pneumocystis pneumonia, Kaposi's sarcoma, and Candida esophagitis, treated with Bactrim, prednisone, Biktarvy, and fluconazole. Patient was discharged home in stable condition under multidisciplinary care team, including primary physician, gastroenterologist, oncologist, and infectious disease doctor, and was closely followed up in PCP office in 2 days. At PCP's office, patient mentioned tolerating the medication well with improvement in his symptoms, but had new complaints of emergence of multiple vivacious nodules on face, back, and abdomen, as shown in the picture. Biopsy was taken. Patient also underwent PET scan, which showed multiple FDG active lymph nodes throughout the body. All the biopsy results from stomach, skin, and lymph nodes came positive for Kaposi's sarcoma, and patient was ultimately started on treatment with doxorubicin. Discussion about Kaposi's sarcoma. Although Kaposi's sarcoma has been reported in all risk groups for HIV infection, it is most common among men who have sex with men and bisexual males. GI symptoms can vary from weight loss, dysphagia, to intestinal obstruction or having diarrhea. Regional nodal involvement is relatively uncommon and rarely associated with bulky lymphadenopathy. Involvement of the lungs, liver, and bone is extremely rare. Differentials to consider include bacillary angiomatosis, angiosarcoma, sporotrichosis, Mycobacterium marinum, or skin infections. A biopsy is required to confirm the diagnosis. If GI involvement is suspected, endoscopy should be performed. Although screening endoscopy without GI symptom is currently not recommended. The incidence of KS increases within 6 months of starting antiretroviral therapy, primarily due to immune reconstitution inflammatory syndrome, which can unmask underlying KS. The prognosis of gastrointestinal KS is poor in both organ transplant-associated and AIDS-related forms, with a 6-month survival rate of approximately 40%. Thank you. Hello everyone. I'm Dr. Dilbag Kaur. I'm PGY2 Internal Medicine at Mercy Hospital, Fort Smith, affiliated with Arkansas College of Osteopathic